So more specifically, within the guideline, what we set out to do was to review the hemoglobin cutoffs. We explored using a statistical approach, and we also wanted to explore the use of outcomes related to clinical symptoms and functional impairment in order to inform any revisions. Now, we have to keep in mind that some of these hemoglobin thresholds were developed several decades ago. So we had a lot of work to do to be able to see what new evidence was available to us at that time and see what kind of best available evidence we had in front of us to make our decisions. We also reviewed any of the adjustments to hemoglobin concentrations to account for elevation of residence, smoking, infections, inflammation, genetic ancestry, ethnicity, and race. We also wanted to look at the comparability of hemoglobin determinations by type of blood sample, by method of analysis, and by the different types of analytical instruments that are available to us today. We wanted to review how hemoglobin concentrations change in response to an intervention. And we also wanted to review the categories of anemia prevalence at the population level that could be indicative of a public health problem of either mild, moderate, or severe magnitude as well. So I'll go through the slides and I'll summarize each of the guidance that was delivered in these 5 areas. Okay, there we go. So there was a preference for looking at the thresholds based on outcomes that were related to the clinical symptoms and functional impairment. We really wanted to be able to say at this hemoglobin level, we start to see functional impairments or impaired functions. But it was not possible. We couldn't, there was not enough data available to us on these clinical symptoms, and therefore we had to resort to using the statistical approach for defining our thresholds. What we did is we calculated the 5th percentile of hemoglobin distributions that were derived from apparently healthy populations. And these populations were pretty ethnically diverse, but they were predominantly from higher income settings such as Australia, China, Europe, North America, and South America. There was a couple from Asia as well, and we did look at some data from lower income settings, and we considered that information too. Using this approach, most of the current thresholds were validated, meaning that there was no change to most of those thresholds, but in children 6 to 23 months of age, there was a slight decrease in the cutoff for defining anemia. And then also, we wanted to revert back to using thresholds that were defined by trimester of pregnancy. Now, these have been used in some of the programs already, particularly within antenatal care, but we wanted to, we validated that it was important to look at the thresholds by trimester of pregnancy. We also maintained the methodology that was established for the severity of anemia in an individual, as we did not have any further sufficient evidence for alternate methods, such as health or clinical symptoms as well. So this is what the hemoglobin threshold table looks like for defining no anemia, mild, moderate, and severe anemia. And you can see just in the red boxes, those are the ones that have changed. So the thresholds for children 6 to 23 months of age, and then reverting back to the thresholds by trimester of pregnancy that were shifted downward. Okay. Now there were also work done by our colleagues at CDC. This is a very collaborative effort, and the CDC team were able to obtain different data sets that looked at the impact of elevation at the place of residency on hemoglobin concentrations. And this is due to the lower oxygen partial pressure at the higher altitudes, causing a physiological response of increasing the red blood cells and increasing hemoglobin. So we did confirm that adjustment is necessary, and we were able to, with this additional data, revise the previous adjustments factors that we were recommending for elevation. So some of the major changes are that we are adjusting hemoglobin concentrations for elevations starting at 500 meters. We used to start just at 1,000 meters, and now we're adjusting at a lower level. There's also relatively larger adjustments for those residing below 3,000 meters of elevation, and a relatively smaller adjustment for those residing above 3,500 meters. Now, I would say probably about 98% of the population resides at below 2,500 meters, so there's probably going to be larger adjustments overall for populations. The users have an option to use the categorical adjustment factors that is provided on that table starting at 500 meters, or when specific information is known about the elevation at the place of residence, a formula can also be utilized, and that formulation is provided at the very bottom of the table there. These adjustment factors can be applied by subtracting the amount recommended from an individual's observed hemoglobin level, or by adding the amount recommended to the existing hemoglobin cutoff. So there's different ways that you can apply it. Now, CDC also helped us with looking at some of the adjustments for smoking, and they used some of those same data sets as for elevation. And the main difference that we have this time around is that the adjustment factors are now given in terms of number of cigarettes smoked per day rather than number of packs per day. And again, we have the possibility of using a categorical adjustment factor or by using a formula as well. We definitely wanted to look at some of the information out there about the use of vaping products or e-cigarettes, and also looking at like shisha pipes, looking at indoor smoke, but there was not enough information available to us to make recommendations for those products as well. But just knowing that smoking is very important to be able to adjust for. So looking at adjustments for inflammation, we know that infections that cause inflammation are common, and they do contribute to anemia of various severity. However, adjustment of hemoglobin for inflammation was not felt to be the appropriate approach, as anemia may be the consequence of the infection itself, or the disease that is causing the inflammation. So there's no recommendation, or there's a recommendation not to adjust for infection or inflammation. And likewise, we know that there are some observed differences in hemoglobin across age and population groups for apparently healthy populations, and some of these differences may reflect some of the changes in the genes related to hemoglobin production and or other aspects of red blood cell production or function. However, at this time, there is insufficient evidence to suggest that any adjustments based on genetic ancestry, ethnicity, or race was needed to adjust for. Now, looking at the measurements of hemoglobin, the use of venous blood and automated hematology analyzers, as well as good quality control measures, are recommended. There is noted a great variation in hemoglobin values obtained from capillary and venous blood samples. However, this magnitude of variation is different across different studies, and it was not possible for us to be able to provide adjustments to hemoglobin that is measured in the two different types of blood, either the capillary or the venous, in order to make them comparable to one another. We really need to give a lot of careful consideration to the blood source and the type of analyzer that is used in data collection when tracking changes in hemoglobin and the prevalence of anemia over time, and be careful as we compare them across different settings. There is a lot of information that is starting to come out about using pooled capillary drops, and we know that there's still a lot of research that is going on to do with the pooled capillary samples, and so we really want to make sure that we see additional research before we come out with a recommendation about this pooling. So we're grateful for all the research that's happening, but yet still to make a recommendation about its use. There is a note that if you cannot use the automated hematology analyzer, then considering the point of care blood device is possible. We know that there's some really good ones out there, but we must make sure that they're validated and to be calibrated against some of the international reference standards as well. We do emphasize the use of good quality control measures at all points, whether that's in the pre-analytical phase, the analytical phase, or the post-analytical phase as well. And we want to make sure that those get incorporated into all the different procedures as well. So when we look at the impact of different interventions and using hemoglobin values to be able to assess that, it was felt that hemoglobin concentrations are valuable when measuring an impact of an intervention, whether that be an iron intervention or other type of intervention when addressing anemia. But we also really encourage the use of additional indicators for measuring at least iron status, so looking at ferritin, serum transferrin receptors, along with other markers of inflammation. These are really important for us to be able to assess some of the etiology. So in addition to using the hemoglobin to look at the impact of an intervention, we really should try to also measure other indicators as well, but this was felt to be a good one. And then finally, it was recommended that the current classification of the public health significance of anemia prevalence in populations should be maintained. And this is based on the prevalence of total anemia. There wasn't any good evidence to show a clear association between the severity of the public health burden of anemia with any of the clinical or demographic outcomes that would inform a change. So this is the categorization that we've been using since about 2000, and this should be maintained until new evidence becomes available. So here we have that a prevalence of 40% or higher is considered to be a severe public health problem of anemia. A population prevalence between the 20 and less than 40 is felt to be moderate. Prevalence between 5 and less than 20 is mild, and then less than 5 is felt to be a normal population prevalence of anemia. So with that, I'd just like to thank our collaborators. We worked with the Australian Walter and Eliza Hall Institute of Medical Research, who did a lot of the statistical approach on looking at the hemoglobin cutoffs for us, CDC, who was involved in a lot of the work on looking at adjustments for elevation and smoking, and then, of course, the financial support from the USAID as well. So really grateful to all the partners and all the experts that were involved in this decision-making process for updating these guidelines. Thank you.